Today's topic is the assessment and management of endometrial hyperplasia and carcinoma in patients undergoing progestin therapy. For patients with atypical hyperplasia, also referred to as endometrial intraepithelial neoplasia, EIN, and those with well-differentiated endometrioid adenocarcinoma, the treatment of choice is hysterectomy. However, for younger patients desiring fertility preservation or for those who are poor surgical candidates, progestin therapy offers a safe and effective alternative. Progestin therapy results in a 60 to 70% regression rate for patients with atypical endometrial hyperplasia and well-differentiated endometrioid adenocarcinoma. Following successful treatment, patients may pursue pregnancy or continue progestin therapy as a means of avoiding hysterectomy. However, treatment failure occurs in approximately 30 to 40% of cases, ultimately requiring definitive surgical management. Therefore, close monitoring of treatment response is critical. Endometrial sampling via biopsy should be performed at 3, 6, and 9-month intervals during progestin therapy to assess for response or disease progression. Pathologic evaluation plays a critical role in assessing treatment response. As illustrated in this table, there is a progressive decrease in architectural and cytologic atypia over time with progestin therapy. By 7 to 9 months of treatment, the persistence of either architectural or cytologic atypia is indicative of treatment failure. Notably, patients with persistent atypia at this stage did not achieve regression or resolution with continued progestin therapy, highlighting the importance of timely histologic reassessment. Now let's examine the morphologic features of endometrial atypical hyperplasia and well-differentiated adenocarcinoma following progestin therapy. This image demonstrates histologic resolution of disease. The endometrium shows abundant stroma with widely spaced endometrial glands, lacking glandular crowding or architectural complexity. The glands are atrophic and exhibit no cytologic atypia, which are hallmarks of a favorable treatment response. This image demonstrates persistent disease. While there is abundant stromal background and occasional atrophic glands, features consistent with progestin effect, there remain areas of crowded endometrial glands with squamous whorls. Even at low magnification, the glandular epithelium in these crowded areas is morphologically distinct from the solitary atrophic gland. These findings indicate both architectural and cytologic atypia, consistent with treatment failure. While most cases are straightforward to diagnose, some can be challenging. In this image, the background shows abundant stroma and scattered atrophic glands, consistent with progestin therapy. However, certain areas display glandular crowding, raising concern for persistent disease. At higher magnification, the crowded glands exhibit secretory changes, with cytologic features that are distinct from the background atrophic glands. This raises the question, is this glandular crowding enough to diagnose architectural atypia? And, is this cytologic difference enough for cytologic atypia? And ultimately, do these findings represent residual disease? This is another case. We see focal cytologic atypia in the background of progestin effect. These nuclei are enlarged. At higher magnification, these atypical cells exhibit nuclear enlargement and prominent nucleoli. The key question arises, do these features meet the threshold for cytologic atypia indicative of residual disease, or are they better interpreted as benign metaplastic changes? Let's now address these questions by reviewing the diagnostic criteria for architectural and cytologic atypia in progestin-treated atypical endometrial hyperplasia and endometrioid adenocarcinoma. Histologic changes seen in progestin-treated endometrial hyperplasia and adenocarcinoma include a decreased gland-to-stroma ratio, reduced glandular cellularity, loss of cytologic atypia, and decreased or absent mitotic activity. In addition, a range of cytoplasmic alterations may be observed, including mucinous, secretory, squamous, and eosinophilic metaplasia. Here we see decreased gland-to-stromal ratio in atrophic glands. There is no architectural or cytologic atypia. In the context of progestin-treated endometrium, cytologic atypia is defined by the presence of coarse chromatin and/or prominent nucleoli. In the previously shown image, prominent nucleoli are evident, features diagnostic of cytologic atypia and therefore indicative of residual disease. In the image on the right, both coarse chromatin and nucleoli are present, again confirming cytologic atypia and persistent disease. Importantly, this latter image might be mistakenly interpreted as a benign Arias-Stella reaction. However, in the setting of progestin-treated endometrial hyperplasia or carcinoma, close attention to subtle cytologic features is critical to avoid underdiagnosis. In progestin-treated endometrium, architectural atypia is defined by the presence of glandular crowding and or cribriform or papillary glandular patterns. These findings reflect persistent abnormal glandular architecture and are diagnostic of residual disease. In this image of progestin-treated endometrial atypical hyperplasia, the inset shows the pre-treatment biopsy. Post-treatment, the glands appear atrophic and cystically dilated. However, the gland-to-stroma ratio remains elevated, indicating persistent architectural atypia and residual disease. In this image, we observe a papillary architecture. These papillae are often lined by cytologically bland epithelium, sometimes with mucinous differentiation. However, regardless of how benign the lining appears, the presence of any papillary structures is diagnostic of architectural atypia and indicates residual disease. Similarly, any cribriform gland indicate architectural abnormality and residual disease. This table shows that in biopsies taken at 7 to 9 months, the presence of cytologic atypia or cribriform and or papillary architecture is strongly associated with treatment failure. None of these patients experienced resolution or regression. In contrast, cases with glandular crowding but without cytologic atypia or complex architecture, cribriform or papillary, still had the potential for disease regression. Therefore, glandular crowding alone is less concerning. To conclude, evaluating atypia in progestin-treated endometrial hyperplasia or well-differentiated endometrioid adenocarcinoma can be challenging. There are two key forms of atypia to assess: cytologic and architectural. Cytologic atypia is defined by the presence of coarse chromatin and or prominent nucleoli. Architectural atypia is identified by glandular crowding with cribriform and or papillary patterns. The presence of either cytologic or architectural atypia, or both, is diagnostic of residual disease and indicates treatment failure. In daily practice, it is helpful to compare the current biopsy with the patient's prior specimens, specifically evaluating the degree of architectural and cytologic atypia. Is the atypia stable, progressing, or regressing? Providing this context allows the clinical team to make more informed decisions regarding the next steps in patient management. Here are sample diagnostic phrases we use in practice, depending on treatment response. For disease resolution, benign endometrium with progestin effect. No evidence of residual disease. For residual disease, focal residual hyperplasia with/without atypia in a background of progestin effect. We usually include a comment on whether the findings are similar to, improved, or worse than the prior biopsy if the prior biopsy is available to review. For disease progression despite treatment, endometrial intraepithelial neoplasia, EIN, or well-differentiated adenocarcinoma in a background of progestin effect. We usually specify that the findings are increased compared with the prior biopsy. Additionally, if there is no histologic evidence of progestin effect, it is important to document this explicitly, as it may indicate non-compliance or treatment failure.